Good evening and welcome to What Clinicians Want to Know, addressing community oncologist questions about the roles of CAR T-cell therapy and bispecific antibodies in the management of non-Hodgkin lymphomas. I'm Jeremy Abramson from Mass General Hospital in Boston, and I'll be moderating today's program. Here's our faculty. I'm delighted to be joined by wonderful colleagues and friends on the podium today. Here we have Dr. Joshua Brody from Mount Sinai in New York. We have Dr. Tycel Phillips from City of Hope in California. We have Dr. Jason Westin from MD Anderson Cancer Center in Houston, Texas, and Dr. Manali Kamdar from the great state of Colorado. I'm going to scroll through our relevant disclosures. Interesting, Dr. Brody.
Thank you. I'm open to more conflicts if you want to.
Well, you heard it here first. These are Neil's disclosures, and I will also note that the Research to Practice Committee staff and reviewers have no conflict of interest to disclose. Today's program will contain discussion of non-approved use of agents and regimens. Please refer to official prescribing information for each product and approved indication. Now, in order to make this meeting more relevant to participants, a survey of 50 general medical oncologists was conducted earlier this month. Questions and cases were provided from that survey, and those will be posed to the faculty throughout tonight's program. And this is where we're headed this evening. Dr. Kamdar is going to kick us off with CAR T-cells for diffuse large B-cell lymphoma. Then Dr. Westin will discuss bispecific antibodies for DLBCL. I'll then cover CAR T-cells for other lymphomas. Dr. Phillips will talk about bispecifics for follicular and mantle cell. And then Dr. Brody will close us out by talking about tolerability and safety with CAR T-cells and bispecific antibodies. So let's kick off our first module and welcome to the podium Dr. Kamdar to talk about CAR T-cell therapy for diffuse large B-cell lymphoma. Manali.
Thank you very much. Very good evening to everyone. I'm going to kickstart, as Dr. Abramson alluded to, and discuss where we are with chimeric antigen receptor T-cell therapy, CAR T-cell therapy for diffuse large B-cell lymphoma. So the pre-CAR T era was obviously really marred with dismal prognosis for patients with relapsed refractory, chemotherapy-resistant large B-cell lymphoma with a median overall survival that was less than 6 months. And then came the advent of 3 constructs with CD19 CAR T-cell therapy, each of them tested in 3 pivotal studies, ZUMA-1 testing axicabtagene, Juliet with tisagenlecleucel, and Transcend with lisocabtagene. I think the audience here is quite aware the difference between the constructs also reflects in the toxicities as a function of how CARs work. And the difference in the constructs really primarily hinges upon the co-stimulatory domain. With axi-cell, the co-stim domain is CD28, as a function of which the CARs expand fast and robustly. On the other hand, with the 4-1BB domains, the CARs expand slowly and they are more controlled. And as I will show you some data, that is also reflected in some of the pivotal studies across the 3 constructs. Of course, there are no randomized clinical studies in the third-line setting when these constructs got approved, but this is a head-to-head comparison done in terms of understanding the age groups that were actually included in these 3 pivotal studies. Time and again, I will reinforce here that age is not a contraindication for CD19 CAR T-cell therapy. Take into account, with Transcend study, the median age was 63, but with a variation from 18 to 86. And each one of us in our practice have had septuagenarians, octogenarians, and rarely even nanogenarians get on to CAR T-cell therapy. With regards to lymphoma subtypes, it was primarily for large B-cell lymphoma, but also included primary mediastinal B-cell lymphoma, transformed indolent lymphoma, as well as patients who had had CNS involvement and patients who had progressed after prior allogeneic transplant. It's important to highlight that in a heavily pretreated scenario, across the 3 studies, the overall response rate was upwards of 70%, with a complete response rate between 40 and 50%. Like we talked about with regards to the co-stim domain, you do see a difference with grade 3 and higher CRS, as well as grade 3 and higher neurotoxicity. With CD28 domain on the ZUMA-1 axi-cell study, you see a grade 3 or higher CRS of 11%, grade 3 or higher ICANS or neurotoxicity of 32%. This contrasts with lisocabtagene with a grade 3 or higher CRS of 2% versus a grade 3 or higher ICANS of 10%. These studies were also done at a time when standardization of CRS, management of CRS, grading of CRS and ICANS was not quite understood. Now we do follow something called the ASTCT algorithms. However, this remains to be seen in terms of the CRS and ICANS. It is quite similar in terms of what we see between a 28 and a 41BB CAR. But the net is that in a heavily pretreated setting, with the long-term follow-up, we now see cures. This was unheard of. Previously, all we had was chemo after chemo after chemo, but now in a heavily pretreated diffuse large B-cell lymphoma relapsed refractory setting, we are now able to get a plateau of 40%. 40% patients who would have otherwise succumbed to CAR T-cell to their lymphoma can be actually salvaged with CAR T-cell therapy. So obviously, if something works in third line, we want to bring it to second line or even front line. And I'm going to show you some data, how the PFS curve actually steadily keeps going up with CD19 CAR T-cell therapies. So there were 3 clinical trials, randomized phase 3 clinical trials that tested CD19 CARs versus salvage chemo followed by an auto transplant in second-line relapse diffuse large B-cell lymphoma that was either primary refractory or relapse within 12 months after initial chemoimmunotherapy. We know historically that this high-risk second-line DLBCL does not actually benefit from an auto transplant, even if patients are transplant eligible and go through an auto. So ZUMA-7 tested axi-cell versus standard of care, which was the auto, transform, lysocell versus standard of care, and the same with Belinda. Now, the audience here is very well aware that of the 3 clinical trials, Belinda was a negative study. On the other hand, ZUMA-7 and Transform both met its primary endpoint, which was event-free survival. CD19 CAR T-cell therapy was statistically superior, significantly superior with regards to event-free survival as well as progression-free survival for both of these 2 studies, and it beat auto transplant. Auto transplant has been a 3.5-decade-old standard previously for second-line diffuse large B-cell lymphoma fit patients, and at this point in time is no longer the case. Now the standard of care is CD19 CAR T-cell therapy. Overall response rate was higher compared to auto transplant. Complete response rate was 65 to 70% on the CAR T arm versus only 30 to 40% on the auto transplant arm. You can also see that the grade 3 or higher CRS or neurotoxicity was 6% and 21% respectively on the ZUMA-7 study and 1% and 4% on the lysocell study. Let's move to understanding if we take our patients to CD19 CAR T-cell therapy, they beat auto transplant, but is it still curative is the question. And the answer is yes. We now do have a higher rate of survival demonstrated with CD19 CAR T-cell therapy versus auto transplant. And this is Dr. Westin's data, where axi-cell continued to show a higher rate of survival that was statistically significant versus auto transplant at the 4-year follow-up, translating into a 27% reduction in risk of death versus auto transplant. In the ZUMA-7 study, steroids were permitted as bridging therapy. In the ZUMA-7 study, patients were not able to cross over to the experimental arm, which is CAR T-cell therapy on protocol. Now let's look at the lysocell follow-up. The lysocell follow-up at the 3-year also looks pretty much the same. However, it's important to understand that lysocell bridging therapy was permitted with 1 cycle of salvage chemotherapy, and 62% of patients actually had crossover from standard of care to receive lysocell. Despite that, you can see that the progression-free survival continues to favor lysocell as compared to autotransplant. But the overall survival right now is not statistically significant, yet there is a difference. And it's probably a function of the crossover. A big question that our community partners ask us, what does it actually matter if we give CAR T-cell therapy in 3rd line versus 2nd line, which is if somebody relapses, I give them chemo. If they go into a remission, I wait, and then they relapse, and then I get them to you for CAR T-cell therapy, versus if someone relapses in 2nd line, I get them to you right away. And I think this is the question that gets answered in the long-term follow-up, because we have now patients on the Transform study that crossed over to getting lysocell on study in 3rd line. And you can see there's a difference. The 24-month rate for EFS is 95% versus 70% with patients who receive lysocell in 3rd line. So it does matter. Now we have seen patients who have now gotten cured up to 40% in 3rd line with CD19 CAR T-cell therapy, and now the cure rate has been bumped up to about 50 to 55% with 2nd line. The big question in our group or in the field now has been, what does it mean for the patient? And this is a variable that is gaining a lot of prominence called patient-reported outcomes. Both of these studies, Transform as well as ZUMA-7, we did show clinically meaningful improvement in quality of life for patients that got randomized to CAR T-cell therapy compared with autotransplant. So moving forward, after these studies were published, the FDA approved lysocell as well as axi-cell as the standard of care for high-risk 2nd-line diffuse large B-cell lymphoma patients that were transplant eligible. So the big question is, what about transplant ineligible patients? And here, the pilot data answers the question. This is a phase 2 single-arm study of patients who are transplant ineligible with relapsed refractory large B-cell lymphoma. And in this patient population, you can see that there is an overall response rate of 80% with a CR rate of 50%. The primary endpoint was met. The median overall survival at the 18-month follow-up is not yet reached. Logistics. They have been quite the bane of CAR T-cell therapy. At this point in time, as everybody knows, we first have to undergo apheresis, followed by bridging therapy, followed by CAR T infusion. Not everybody needs bridging therapy. Bridging therapy may be optional, and in this case is typically dependent on tumor cadence, patient preference, and where the patient is located. Why early referral matters? I'm going to steal a phrase of my colleague, Dr. Lunning, who talks about brain to vein time. Brain to vein basically means if you think a patient has relapsed, please initiate the referral. Don't wait to confirm it, because time is getting lost and the cancer is not waiting. Real-world analyses, the Komodo claims data actually shows if 10 patients are eligible to getting to CAR, only 2 actually get referred. We are really trying to figure out why access is so poor in a country where CAR T-cell therapy got approved the first. So early referral matters because improving access, improving planning, getting insurance authorization matters before we even get the patient on the machine for apheresis. A lot of times we can facilitate telehealth visits. We can facilitate patients' ease with regards to logistics. Please, if the patients recur, refer them to us. The big question is, who is CAR T-cell therapy eligible? And at this point, the biggest takeaway from my talk is that transplant eligibility is not the same as CAR T-cell therapy eligibility. And it's important to highlight this because with transplant, we had strict parameters. We typically don't take patients over the age of 75 to a transplant. We don't take patients with an EF of 40% to a transplant. With poor PFTs, we do not take them to a transplant. With rip-roaring disease, we don't take a patient to transplant. None of these are contraindications for CAR T-cell therapy. The trick that I usually really convince my community partners is we don't need a response, we just need stability. We don't need our patients to be sensitive to any treatment prior to CAR T-cell therapy. Whether they are in a partial response, stable disease, or progression of disease, they are all CAR eligible. Age is not a contraindication, but optimization of organ function is the need of the hour. And that's another reason for why early referral matters, so that we can get our specialists such as nephro-oncologists, cardio-oncologists, pulmonologists to be able to optimize their organ function, and thus the toxicity can be minimized. I would say if you think a patient can tolerate GEMOX, please consider them for CAR T-cell therapy if the patients have relapsed.
Great. Thank you, Dr. Kamdar. Let us go to our cases, and these cases, again, submitted by general medical oncologists, and we're going to bend the ear of my colleagues on stage. We'll start out with an 80-year-old man with stage 4 DLBCL, non-GCB subtype. Patient has coronary disease, stage 3 chronic kidney disease, and a fib on anticoagulation. This patient got R-CHOP as initial treatment, had an initial CR that lasted 3 years, relapsed, and at the time of relapse received tafasitamab lenalidomide as second-line therapy with good response, lasting 2 years. This patient is now progressing and is in need of third-line therapy. This patient is 80 years old. Let me start with Jason and say, is this a patient you would take to a CAR, or would you favor a bispecific?
I think it's important. Dr. Kamdar did an excellent job highlighting. I think it's important to note that there are no true exclusion criteria for CAR T-cell therapy. So the age, the kidney dysfunction, the atrial fibrillation, none of those are hard-nosed for CAR T-cell therapy. It is an individualized decision, and it does require a discussion with a CAR T-cell therapist, somebody who's able to make that determination. But this is a patient that might be a candidate for lisocabtagene based on the pilot trial, even if it was a second-line patient, but this is in third line. And so I think CAR T-cell therapy would definitely be an option to consider for this patient. As I'll talk about in the next section, bispecific antibodies are also a consideration, but we do know that CAR T-cells are potentially curative, which is a great option for patients if they hopefully have many years of life left.
Thank you, and I admire you teasing your own upcoming talk. Tycel, there are 3 FDA-approved CAR T-cells in the third-line setting. Which one would you favor and why?
In this type of patient, I think in the third-line space, Lysocell or Tycel would probably be the 2 products I would prefer, just based on rates of cytokine release syndrome, neurological complications. Axicell in certain centers would still be a consideration, but I think from a safety standpoint, those former 2 would probably be better for this patient given his comorbidities and age at this point.
Dr. Brody, any preference between Lysocell and Tycel?
As Manali showed us very elegantly and thoroughly, Lysocell won a phase 3 trial and Tycel failed to do so. So that's not a head-to-head of Lysocell versus Tycel, but it's the next best thing that we have. They are against a common comparator at around the same time in history, so Lysocell.
So let's continue on this case. So this patient got tafasitamab lenalidomide prior to going to a CAR T-cell, and I'll remind my panelists, in case they'd forgotten, that tafasitamab targets CD19 just as do all 3 of our approved CAR T-cells in the second and third line setting. Manali, if you had a patient who got a prior CD19-directed therapy, does that influence your choice of CAR T-cells? And do you check for CD19 expression?
So I think we have data that assures us that that is not the case. At this point in time, we have preclinical data to state that prior tafasitamab would not impact CAR T efficacy. If anything, it might actually increase CAR T efficacy and decrease CRS. It was a preclinical model. And then we have a small but retrospective study of about 10 patients coming out of Jason's group that did show that it did not matter if patients were pretreated with tafasitamab to be able to get to CAR T-cell therapy. So no, I do not check for CD19. I shoot for a cure if in third line or second line and I would give that chance of a cure to also this patient.
And Jason, question around bridging, which I think we could spend the whole hour on, but why don't you give me a brief summary of how you approach bridging therapy for your patients, particularly when you choose a systemic option versus radiation?
Yeah, bridging therapy to me is sort of if needed. And in that situation, if the patient has symptomatic disease, if the patient has pain, if they have rapidly progressing disease, then I think bridging therapy can be useful. I do not use bridging therapy to try and get the patient's disease burden down to zero, kind of like you would for an autologous transplant. I think bridging therapy can have toxicities and can backfire, risk of infections, risk of potentially not getting to CAR T-cell. So I try and avoid it unless I need to give it. In terms of local versus systemic, it depends on what you're bridging. If you're bridging somebody that has a focal pain point, radiation can be a great option for bridging. If you have someone that's got rapidly growing disease systemically, I sometimes will give chemotherapy as a short-term bridging. I tend to not use a lot of bispecific antibodies because of the time to ramp up dosing kind of defeats the purpose of rapid disease control, but that is another consideration.
And so, I think it's actually quite interesting. We used to think about radiation as something you do for one site, one dominant, bulky, symptomatic site. We now have nice data. You could radiate 4 or 5 different sites. You don't need to go to a very high dose. You can go, sometimes to low doses, even, max 10, 12 gray, have very nice disease control. Sometimes immunotherapies are conflated together, Tycel, so let me just throw this out there. Is bridging therapy something that you think about with bispecific antibodies?
Well, we don't have clear data supporting it, but it is something that has been utilized in study. The French group looked at it in their CAR T-cell exposed patients, and their bridging strategy, if they use bispecifics, did not seem to impact the impact of CAR T-cell therapy. So it is something, again, if you have a specific regimen that you prefer, that you can use prior to CAR T-cell therapy, at least with the limited data we have, suggesting that you don't have a negative impact on the overall CAR product and outcome.
Okay. So let's go to another case. This is a 65-year-old woman. She has stage 2 DLBCL. She gets R-CHOP as initial therapy and then relapses, and just to make it tricky for you, 13 months after initial R-CHOP. And so the question here, Josh, is do you take this patient to CAR, or do you say you're a month too late and I'm going to take you to an autograft and give you high-dose chemo?
Dr. Abramson, thank you. I was specifically told that I would not be asked the hard questions, so I'm a little surprised.
I lied about that.
Yeah,
Dr.
okay,
Brody.
well, you could have been, okay. So the answer is, it's so funny, when do people recur? They recur when you get the PET scan. And if this is why, even though there's no right answer for how to do surveillance PET scans after CR in DLBCL, it is my feeling that every patient should get a PET CT 11 months and 29 days, depending on whether it's a leap year or whatever, after their frontline induction therapy. So yes, this patient, in my opinion, should be getting CAR T because 13 months is 12 months, but the scan got balked and it took them a while to get it. CAR T. Biology doesn't know. This is like the milk doesn't expire that day when it's written on the milk label. The milk doesn't know what's written, and the disease doesn't know that it's 13-month and not 12-month disease.
So we're going to take this patient to a CAR T-cell.
CAR T-cell.
Agreed. Okay, so let me ask you, Manali, you said earlier, and I agree, that CAR has really supplanted auto-transplant. Surely there are some patients, and not some patients who weren't included in the data you showed us. Who would you still say, actually, I would still give this patient rice and an auto?
I think patients who have certainly relapsed more than a year out, we don't have any data in fit patients to take them to CAR T-cell therapy or transplant eligible patients to take them to CAR T-cell therapy. I would certainly try to get them to auto transplant. But again, I do believe that there are certain subtypes where I would veer more towards CAR, for example, double hit lymphomas. I don't think even if patients relapse more than a year out, the transplant data actually does not look good retrospectively. So my preference would still be CARs, but otherwise everybody else would be an auto transplant.
Yeah, the young, fit, late relapser is still that person. Dr. Westin?
Yeah, I agree with that. I would add to that pool, though, if you are giving somebody platinum chemotherapy because of rapid disease progression and they're having an awesome clinical response, if they're chemotherapy sensitive, that might be a person that still could benefit from an autologous transplant. The reason autologous transplant was a standard for a quarter century was because it cured chemosensitive patients. It was the getting to transplant, which was the problem. And so if somebody has a symptomatic site of disease that melts with that one cycle of rice you were trying to give them and you've not yet collected their cells, that might be a reasonable situation. But we saw in the randomized trials, that's a very small minority of patients that will get an awesome response. And so that's kind of an edge case that I might still consider a transplant.
And Jason, we heard from Manali a minute ago, that the efficacy between Lysocell and Axicell looks quite similar between the two pivotal studies. They haven't been compared head-to-head, obviously. She really highlighted the difference in toxicity. So you've got a 65-year-old woman here. She could probably ultimately tolerate either one in the sense of getting through it. How do you approach product selection for a patient like this?
We could spend all night about that one as well. That's a complicated question. And I think a lot of it comes down to which product do you have a lot of experience with, which product do you feel can be delivered in a reliable fashion for your patient quickly. But at the end of the day, I think for treating physicians, the key distinction is refer your patient for CAR T-cell eligibility, not worry about which product you're going to use. I think that you could make a strong case for Axicell for a young-ish person, 65 years old. But certainly toxicities are important, and Lysocell does have a lower rate of high-grade toxicities.
And Tycel, let me ask you the last question for the last case. 53-year-old man with double-hit DLBCL gets dose-adjusted EPOCH's initial treatment, relapses a year and a half later. Young patient, later relapse. What are you going to do?
Yeah, I think as Dr. Kamdar mentioned, the retrospective data we have suggests that auto transplants are not generally very effective in a relapsed double-hit lymphoma. So ideally, this would be a patient that, given there's no approval, technically based on the 18-month designation, obviously not an older patient, this patient, I would start some sort of bridging therapy, likely count this as another line of therapy and try to get this patient to a CAR product. Outside of a situation, as Jason mentioned, that there's some remarkable response. But more than likely, like I said, this is a patient that probably should go to CAR for a best chance of cure, given his age and the aggressiveness of relapsed double-hit lymphoma.
That's certainly probably where they're going to end up. I have to say, if I'm taking a patient to Rice or RDHAP or one of these, if they don't have the best CR possible, I'm typically going to CAR and calling that a third-line treatment. Great. Let's go to our next module. Invite Dr. Westin up to the podium. Jason's going to talk to us about bispecific antibody therapy for DLBCL.
All right, wonderful. Thank you for joining us tonight, and thanks for the opportunity to present. I'm going to figure out how to advance my slides here. It's an IQ test. No, I have to get, okay.
Manali absconded with
Okay, I see how this works here. Okay. Very good. So my charge tonight is to talk to you not about CAR T-cell therapy, but about bispecific antibodies. So that's a great segue to see all the amazing advances in cellular therapy. What about not genetically modified T-cells, but antibody-recruited T-cells into the tumor microenvironment? There's a long precedent of doing antibodies that have more than one target. First off with blinatumomab, which was targeting CD19 and CD3, and that worked quite well in leukemia patients, but didn't have much of a role to play in lymphoma patients, due in part to some challenges for the pharmacokinetics. But there's been an incredible advance, as you can see on the slide here, of new engineering for immune therapies, including bispecific antibodies. And the way I describe these bispecific antibodies to my patients is that this is a treatment that has a different left hand and a different right hand. The left hand, if you will, grabs onto the B cells. CD20 is the target for these ones that we'll talk about in late clinical development. The right hand grabs onto the T cells and brings them up close and personal so that the T cells can now recognize the wolf in sheep's clothing that is a malignant B cell and can attack, whereas floating around in circulation, that's not currently happening without these bispecific antibodies. So they have a lot of similarities, both having the two arms, but there are some differences that you can see here in terms of the number of CD20 binding domains and in the structure of these antibodies. Let's dig into some of the data for some of the pivotal trials that launched these antibodies to being FDA-approved treatments. Glofitamab was initially published in the New England Journal of Medicine now 4 years ago, in a phase 2 study evaluating this in relapsed refractory patients with large B-cell lymphoma. Glofitamab is an IV therapy that has a fixed duration, and it results in my opinion, impressive clinical efficacy, with more than 50% of patients with relapsed refractory large B-cell lymphoma achieving a response with this single-agent immune therapy, and 40% of patients achieving a complete response, which, as we heard in the CAR T-cell talk, historically would have been outstanding compared to what we saw with chemotherapy in the past. The progression-free survival is median of only 4.9 months, but I will show you in those patients who respond, it can be quite durable. Now, Dr. Brody will talk to us in detail about toxicities, but similar to CAR T-cells, bispecific antibodies do have toxicities that overlap, including cytokine release syndrome. And the bispecific version of cytokine release syndrome is usually more of a fever, grade 1 CRS, but it still is notable that more than about 2/3 of patients had some degree of CRS on this study for glofitamab. 1 out of 20 patients had high-grade CRS, 4%, so quite a low rate of ICU admission or significant hospitalization level of toxicities. As I mentioned, if you get a response, about half of patients do, with glofitamab, it can be very durable. And this is updated data showing that these are long-term responders, both for overall response and complete response, for patients historically that would not have seen this kind of durability of response with chemotherapy. Now, another bispecific antibody in the relapsed refractory space is epcoritamab, and this was published in the JCO now also 4 years ago. This is a subcutaneous bispecific antibody, and this is given until either toxicity or progression, so that's an indefinite treatment compared to the fixed duration for glofitamab. But it also has a very impressive response rate. 63% in this initial cohort had a response, and about 40% of patients had a complete response. So in my opinion, these are fairly similar in terms of their efficacy, and also fairly similar in terms of their toxicities. About half of patients here had some degree of cytokine release syndrome, primarily grade 1 and grade 2, very rare high-grade cytokine release syndromes. Epcoritamab, same story. If you get a response, it can be quite durable. Now, what we're not seeing on either of these curves early on is a plateau that we saw in the CAR T-cell curves. That may emerge as we see longer follow-up, but in the early days, there were still relapses happening beyond the time points that we saw in the CAR T-cell trials, where it's sort of an early relapse or no relapse story that we could attribute to the cell therapy. We are going to see some updated data at the EHA Congress in the next few weeks, looking at a combination of, single agent epcoritamab randomized against our chemotherapy, specifically our GemOx or bendamustine rituximab. There's a press release describing this as a positive study that will show the results in greater detail at that Congress. But the preliminary update is that there's a significant improvement in progression-free survival favoring epcoritamab over chemotherapy in complete response rate, duration of response, and a small difference, but a notable trend in overall survival. The toxicities for epcoritamab in the study look quite similar to what we saw in the prior study, of about half of patients having some degree of cytokine release syndrome, primarily being low grade. And so I think this will be an important study that we'll see full updates on this summer. Epcoritamab is more effective than our chemotherapy in this relapsed refractory large B-cell population. Now, this is not the only approach to give these as single agents. We can also combine these with chemotherapies. And this is a study that was led by Professor Abramson, looking at the combination of glofitamab and GemOx versus our GemOx, the STARGLO trial. This was a global phase 3 study looking at the backbone of chemotherapy with and without the bispecific antibody glofitamab. And the results, which are now relatively mature at 3 years, presented last year at the ASH meeting, show a consistent and durable benefit favoring glofitamab over the non-glofitamab chemotherapy. So glofitamab makes our GemOx significantly better for overall survival. This curve on your left is the overall population, including all patients with relapsed large cell lymphoma. The curve on your right is specifically focusing on those in second line, those who had only had one prior treatment. And you can see those curves separate quite early and have a durable separation, showing a significant overall survival improvement favoring glofitamab or GemOx. When you look at patients based upon their landmark analysis of end of treatment response, those patients that had a complete response, which is in the blue, had outstanding outcomes. And this is showing, I would say, cure rates which are in the 80+% range long-term for both progression-free and overall survival. This is in a subset of patients in second line who had a complete response. Could not identify these people up front who would go on to have a complete response. But if the patients were fortunate enough to get a complete response, outstanding outcomes, begging the question of should that be a treatment that's considered for that population. Epcoritamab has also had data combined with R-GemOx in this phase 1, phase 2 study, the NHL2 trial, which was led by Dr. Brody. This showed outstanding response rates at nearly 90% across all patients, 1 prior line or 2 or more prior lines of therapy, with around 2/3 to 3/4 of patients achieving a complete response with durable responses seen on this study, so quite impressive. And if you look at breaking it out by line of therapy, not surprisingly, less heavily pretreated patients tend to do better, with those patients with only 1 prior line of treatment having outcomes at 1 year of about 2/3 of patients being free from progression. Now, looking at a study that we presented last summer, which is evaluating the combination of the bispecific antibody mosunetuzumab subcutaneously and polatuzumab, the IV antibody drug conjugate, here we see a fixed duration, fully outpatient regimen randomized against R-GemOx. And what we saw in this was a significant improvement in progression-free survival favoring mosunetuzumab, nearly tripling the progression-free survival median compared with the historical standard of R-GemOx. These are data that we've updated now at the ASCO meeting in 2026, showing that this separation is continuing to show a strong benefit favoring mosunetuzumab, and hopefully this will be a treatment available to our patients in the U.S. soon. When we look at those second-line patients, again, chemotherapy, less chemotherapy-exposed patients tend to do better with treatments, and we see that mosunetuzumab has an enormous benefit, the median progression-free survival of 17 months versus 3 months in this second-line patient population. Now, looking at the same polatuzumab and bispecific now glofitamab in the frontline setting, these are provocative data presented by the German group, Dr. Chapuis and colleagues, at the ASH 2025 meeting, in frontline patients who are elderly, no chemotherapy in the conventional sense, polatuzumab, glofitamab, and rituximab. And here are the results in untreated large cell lymphoma. At end of treatment, 81% of patients had a complete response with no chopped backbone, which is fascinating. This is now the NCCN guidelines, which is including the use of bispecific antibodies. If you're not intending to proceed to transplant, you can see epcoritamab and glofitamab are listed there, as is mosunetuzumab. This is the trial presented by my colleague, Dr. Daiichi Hara, here at the ASH meeting, looking at can we get rid of anthracycline in elderly frail patients, epcoritamab with mini CBP, and we saw nearly 90% complete response rate in this interim analysis. These are phase 3 trials that are ongoing evaluating bispecific antibodies plus chemotherapy. In the front line, the SkyGlow trial, EPCOR DLBCL2, and the Olympia 3 study evaluating odronextamab CHOP versus R-CHOP. In the relapse space, the DLBCL4 trial is evaluating epcoritamab as a single agent with lenalidomide and against R-GemOx. This is the last slide, and in this trial that we're launching very soon at MD Anderson, we're evaluating glofitamab, polatuzumab, and golcadomide in combination in frontline patients without chemotherapy unless a response is not achieved. And so in conclusion, bispecific antibodies are here to stay. These are highly effective regimens. About 40% of patients achieve a complete response with single agent. Adding in GemOx, that jumps up even higher. And we're highly eagerly anticipating these frontline clinical trials. Thank you.
Thank you, Jason. Let's go to our cases. So this first case is a 58-year-old man with stage 4 DLBCL, non-GCB subtype. This patient gets R-CHOP as initial therapy, has a partial response, followed by progression within 6 months, a really primary refractory disease. This patient, as their next line of therapy, gets polatuzumab, bendamustine, rituximab, has only a transient response, rapidly progresses, and then is taken to CD19-directed CAR T-cell therapy. That patient has a complete response to CAR T-cells, but unfortunately progresses within 6 months. Dr. Brody, let me ask you first a question about the sequencing. Dr. Kamdar put on one of her slides sort of some notation earlier about thinking about the role of bendamustine. If you have a patient you might ultimately be taking to a CAR T-cell with DLBCL, What can you tell us about the use of bendamustine previously?
Let me say quickly that, Benda is just not a great DLBCL therapy, period. And especially in this situation, which is almost all situations when CAR T may be a future consideration. That should be almost all patients. That should diminish the role of Benda ever prior to CAR T therapy. We have, as you know, lots of great, it's retrospective data, but I think of reasonably good quality that recent bendamustine deteriorates or correlates with poor quality of CAR T efficacy thereafter. And it's probably not just a correlation, it's probably a cause, because it's very easy to show that Benda has long-term effects on many patients' T cells. I'll leave it broadly like that. And it's very easy to show that crappy T cells make crappy CAR T. Am I allowed to curse?
It's a little too late for that, Dr. Brody. Tycel, I think most of us would say this patient has progressed on R-CHOP, progressed on Pola-BR, now progressed on a CAR T-cell. I think most of us would be reaching for a bispecific antibody. The question is, what is your flavor of bispecific antibody? What are you going to choose? You're going to do it alone or in combination?
Given where the patient is at this point, I think you have access to single agent plus combination. But given the treatments they've progressed through thus far, I think we've seen the bispecifics plus the partner drug give you a better complete response rate and durability of response in most cases. So I would likely be grabbing a partner drug for the bispecific antibodies in this situation. Given our current NCCN guidelines, obviously you have the bispecifics plus GemOx, you have Moz and Pola, and then as a 2B recommendation, you also have GlowFit Pola. So I think you have a couple different combination options you can choose from. Given the patients already received polatuzumab, likely would be EPCO GemOx or GlowFit GemOx in this situation.
Okay. So next question, of course, and we'll take this to Jason because you work at a big transplant center, Jason. This patient goes and gets a bispecific antibody. Let's say they get GlowFit GemOx, and this patient goes into a complete remission. Is there a role to consolidate this patient with an allogeneic transplant?
I have not sent a patient for an allogeneic transplant in multiple years because we have so many new drugs that are coming along for large cell lymphoma that it is difficult to find a patient that I think would benefit from an allogeneic transplant. We have to remember that there is a relatively significant non-relapse mortality that we see with allogeneic transplant. And so a patient who's in a complete response and has a 10% chance of dying of doing something to prevent a relapse is a problem. Now, I have had situations where I've regretted that, where somebody's had progressive disease, and I wonder if I had a moment where I could have potentially helped them. And a person like this, who's had rapid progression after multiple lines of therapy, it is tempting to have that conversation about should we consider consolidating. I think that there are so many new agents coming along, though. It's not a reflexive thing that I would do for all patients, and it's a minority of patients I would consider that.
And you showed the landmark analysis. A patient had a CR to GlowFit GemOx. Those looked awfully durable. Dr. Brody, do you have a comment?
My comment was your comment, but I'll now, just because you called me, I got to say something now, which is that they had great durable responses, the GlowFit GemOx, maybe EPCOR GemOx as well. But in the very near future, ready for prime time will be, probably some MRD assessment of those patients, and probably we can even better stratify and say you got a CR after GlowFit GemOx and you're MRD negative. I think this will be within a year. We'll just say your prognosis. Look at that; it's amazing.
No doubt that MRD is going to be a big part of the future. Manali, let me go to you and ask you about toxicity monitoring. This patient is now going on to their fourth line of therapy. Tell us how you're thinking about infection risk, particularly in these patients going forward, and a general approach to how you're risk stratifying and whether you offer these folks routine IVIG replacement.
Yeah, absolutely. I think the more heavily pretreated you are with B-cell depleting agents, you are going to be at risk for infection. So infection is the key. Non-relapse mortality, if you look at that in patients who have gone through treatments, infection really is the major cause of non-relapse mortality in a heavily pretreated relapse refractory DLBCL setting. I typically, if I commit somebody to a bispec or a CD19 CAR T-cell therapy in a heavily pretreated setting especially, I will get them on HSV prophylaxis. I will get them on PJP prophylaxis. I'll check their IgG very routinely. And I'm not waiting for an infection. If their IgG is usually less than 400, even if they are in the pink of their health, I typically give them prophylactic IVIG. I think that is something that we absolutely need to make sure so as to decrease that non-relapse mortality secondary to infections.
Let's go to our next case. This is an 81-year-old woman, stage 4 diffuse large B-cell lymphoma, non-GCB subtype. She's frail. She has Parkinson's disease. She gets our mini-CHOP as initial therapy, has a CR, but at 13 months, this patient is relapsing. I think we've already said together there's no upper age limit for CAR T-cell therapy. So let me ask you, Josh, how are you going to approach in this older, frailer patient, 81 years old? Is this a patient you would still consider for a CAR T-cell, or given the data, would you favor a bispecific?
Yeah, age is a number, and the definition of elderly, we should all be aware, it is defined very specifically as whatever your boss is plus 10. So, we may have a different perception how elderly this patient is, but again, her performance status with her Parkinson's and the fact that her primary oncologist felt she was more of an R-mini-CHOP patient gives you a bit of pause. I think she should meet the CAR T team and discuss if liso-cel would be appropriate, but I would say the majority of these folks are the types that ended up on either a STARGLO-like trial or a bispecific plus antibody drug conjugate study, and now that those have NCCN recommendations, even if not FDA labels, those things float pretty high to the top for her.
Yeah, I agree. I would certainly talk about both options, but I would absolutely consider a candidate for liso-cel, but if she felt more comfortable with the bispecific approach, that would be totally reasonable. So for a patient, Tycel, who you are going to use a bispecific antibody, and you're going to choose monotherapy, here's $1 million question. I know you have a number of children, Tycel, and you love them all equally. How do you pick your favorite, epcoritamab or glofitamab?
If we are going by my kids, it's the day of the week, so that may change. In this situation, I think for most of us, if we have a situation with a patient, a lot of it comes down to the patient's age, fitness, and sort of long-term outlook. So as we do know, glofitamab is a finite duration treatment. Epcoritamab is a treat to progression. So in some ways, you have to guess when to stop epcoritamab in certain patients because we don't have any data per se. And so in a lot of these cases, if our experience is with both, a lot of times we're choosing glofit. But there are some centers that are just epcoritamab centers. So I've done both. I will say since both drugs have been approved, we have likely treated more patients with glofit than epcoritamab, only because we know exactly when to stop the patients. And it's less steroid utilization with glofitamab than we have with epcoritamab, and less visits to the cancer center.
And Jason, we heard about time limit, I think is probably the biggest factor differentiating, but there are others. Are there other factors that you think about in selecting a product?
Yeah, the intravenous versus subcutaneous is another important difference. And so for patients to be able to have less time in the clinic, sometimes subcutaneous injections could be useful. If your center has a limitation on chair time, that could be useful. But the treatment I would prefer for this patient would probably be neither epcoritamab or glofitamab. I would probably look more at the Mosun-Pola regimen because of the response rate being quite robust, but the toxicity being quite favorable compared to the single agents for epcoritamab or glofitamab. I didn't have time to go through all of the toxicity data, but the Sunmo trial showed very low rates of real CRS for Mosun-Pola. And for somebody like this who's quite frail, I agree with everything Dr. Phillips said, but I would probably not choose either of those. I would probably go for the Mosun-Pola because of the low CRS rate.
So let's go to our next case. This is a 56-year-old man with DLBCL presenting with bulky right cervical adenopathy. This patient is primary refractory to POLA-R-CHP as initial treatment, listened to Dr. Kamdar's lecture, went to CAR as second-line therapy, but quickly relapsed just 6 months later. So, Manali, you got a primary refractory patient to POLA-R-CHP. What would you offer?
I think if someone relapsed after Pola-R-CHP and then CAR T-cell therapy, the timing of the relapse matters. I think in this case scenario, I'm not sure if the patient initially responded to relapse at 6 months, but 6 months is a good point for me to get them started on a CD20 bispecific T-cell engager. However, if their tumor biopsy does not express CD20, then CD20 bites are out. I think in those case scenarios, we probably would have to go for other agents that are available, as well as some newer promising treatments.
And is it safe to say, because we heard about a number of combinations that included POLA, this patient's primary refractory frontline POLA, I assume you're not going to reach for a POLA-containing regimen in third line?
Absolutely. I think they are primary refractory to the MMAE payload, so I think retreating them with POLA would be really a waste of time.
And there are a number of new options coming along, Josh. Thinking about this patient and in need of potential future therapies, is there something sort of coming along that if this patient progresses on a CD20 bispecific that you might be excited about?
Yes, we're very lucky, we are and our patients are, that the rate of progress here is unprecedented, unparalleled. We have literally new things coming every year, and specifically, as kind of maybe hinted here, we already have a lot of data of CD19 bispecifics, specifically the one that's furthest along is from AstraZeneca called Suravatimig, but also a Merck CD19 coming close behind it, and some others. And the early data in many lymphomas, but DLBCL included, are awesome single-agent therapy response rates and CR rates, so that's very high on the list. We have other things in this setting as well. We should remember, a randomized phase 3 trial of rituximab plus brentuximab plus lenalidomide, because this patient has not received any of those. So that's not a pipeline. That's already here today. And also, there's never been really a good randomized phase 3 trial of common sense. And if there was literally just a right neck recurrence, you're allowed to include radiotherapy if it were literally an isolated recurrence. We don't have the data for how great, single-site recurrence has a long-term remission with radiotherapy, but it's on the list as well.
Great. Let's go to our next module. And for this module, I'll get to talk about CAR T-cell therapy in diseases other than diffuse large B-cell lymphoma. And I'll specifically talk about follicular lymphoma, marginal zone, and mantle cell. Let's first start talking about these indolent B-cell lymphomas, follicular and marginal zone. There are, once again, 3 FDA-approved CAR T-cell products for third-line and later follicular lymphoma. You've heard of these products already, Liza-cel, Tycel, and Axi-cel. Thank you, Josh. These are very similar trials in the sense that they are non-comparative phase 2 trials. These are not randomized trials. They're all in heavily pretreated follicular lymphoma, though I will note that the Elara trial of Tycel was more heavily pretreated and more refractory. And that's important when we think about the data from these trials. You can see that the Tycel trial had 4 prior lines median compared to 3 median prior lines with Axi-cel and Liza-cel. There's also a higher proportion of chemo-refractory patients in the Tycel trial, 78%, compared to just over 2/3 in both the Liza-cel and Axi-cel trials. Nonetheless, the responses across the board were really outstanding for CAR T-cells in follicular lymphoma. You can see here overall response rates as high as 97% with Liza-cel, 94% Axi-cel, 86% Tycel, and CRs in the vast majority of patients. You can see CRs ranged from 69% with Tycel, 79% in Axi-cel, and 94% of patients on the Liza-cel study achieving a CR with multiply pretreated follicular lymphoma. CAR T-cells induce deep remissions in multiply pretreated follicular lymphoma. Now, we are seeing a signal from the toxicities that Dr. Kamdar talked to us about in her presentation. We see the highest rate of CRS with Axi-cel at 82%, compared to only 49% and 58% with Tycel and Liza-cel, respectively. But in follicular lymphoma, what you can see is this was mostly low-grade with all products. Still, the highest rate of severe CRS was with Axi-cel at 7%, whereas it was 0 or 1% with the 241BB products, Tycel and Liza-cel. Similarly, neurologic side effects, much less common with Tycel and Liza-cel. And this, for me, is what impacts my choice of products in follicular lymphoma. There's still 60% of patients with Axi-cel getting CRS, severe in 15%. And that's tough in an indolent lymphoma. So I'm really not favoring Axi-cel in my follicular lymphoma patients. I don't want them to get high-grade neurotoxicity with an indolent lymphoma. And you can see the rates of any grade and severe neurotox with both Tycel and Liza-cel are extremely low. Question is durability, and how often do these responses last, and are they working in high-risk patients? Well, here's the durable data at 5 years from the ZUMA-5 trial of Axi-cel. What you can see at 5 years, half of patients remain progression-free, and that includes the follicular lymphoma patients as well as the 31 patients included on this study who actually had marginal zone lymphoma. And if we look at the forest plot, what we can see is in general, we see an encouraging PFS rate across high-risk subsets. I will note that the high FLIPI patients and the high tumor burden patients are veering a bit less durable on the progression-free survival curve, and perhaps that reflects tumor burden, and we know that tumor burden is a predictor of durable PFS across CAR T-cell studies. And then we get to that sticky wicket of prior bendamustine. We use a lot of bendamustine in follicular lymphoma. Should we stop giving bendamustine as initial therapy for follicular lymphoma if it's going to poison T cells that we ultimately want to make into a CAR? And the good news is that the vast majority of patients not only respond well to frontline bendamustine, but those responses last for many years. And if we look at when patients receive prior bendamustine in this study, as long as these patients received bendamustine more than a year later, they had similarly favorable responses to Axi-cel as benda-naive patients. It's really those patients within 6 months, within 12 months of prior bendamustine, where we're seeing less durable remissions in these patients. What about Tycel? We do have Tycel is confusing. Tycel, I'm not talking to you. Tycel is a CAR T-cell. Tycel is our colleague. It's tricky for all of us. Here we see 5-year data for Tycel. Median progression-free survival at 53 months. One again at 5 years, just under half of patients remain progression-free. And if we look at high-risk subsets, once again, we're seeing encouraging remissions in multiple high-risk subsets. However, high-risk disease is still high-risk disease. So if patients had POD24, if they had bulky disease, or if they had a high FLIPI score, their PFS appears somewhat inferior compared to those patients without that risk factor. But I think importantly, if you look at the cadence of these curves, even the high-risk patients could have a very favorable and sustained progression-free survival. And then looks at Liza-cel. Liza-cel has the most limited follow-up, so we have 3 years rather than 5 years. But again, these data are looking outstanding. 3 years, 2/3 of patients, 68%, remain progression-free. And if we look at high-risk subsets, once again, we do see some impact about high-risk subsets. Patients with POD24, bulky disease, or double refractory disease are not having the same 3-year PFS as patients without those risk factors. But nonetheless, the majority of patients with those risk factors still have durable PFS at 3 years. You can see nearly 60% of POD24 patients remain progression-free at 36 months, 60% of bulky patients, 60% of double refractory patients. And once again, we can look at the impact of prior bendamustine, and encouraging on this study whether patients received bendamustine within as long as it was longer than a year when they got leukapheresis for CAR T-cells, they had a similar duration of response, whether they had no prior bendamustine or whether it was 1 to 2 years or more than 2 years. But look at the curve that's not doing well at all. Those are the patients that had bendamustine within 12 months, and that duration of response curve drops like a lead stone. And so I recognize I'm mixing weighty objects, and you'll bear with me. But the message is benda within 12 months is not a good idea. What about marginal zone lymphoma? We do have one pivotal trial in marginal zone, and this was a study of Liza-cel. These are the pivotal data here, which did lead to the only FDA approval for CAR T-cells, with Liza-cel approved in the third-line and later setting for relapse refractory marginal zone lymphomas. And this is of any of the flavors of marginal zone: nodal marginal zone, extranodal, or splenic marginal zone. You can see 95% of patients responded, 62% of patients had a complete response. And look at that progression-free survival curve. These are 2-year data. And at 2 years, what you can see is nearly 90% of patients remain progression-free at 2 years. 86% of patients progression-free at 2 years. Obviously, that is still limited follow-up in an indolent disease, so we need to see ongoing follow-up. What about the side effects with marginal zone lymphoma? Generally favorable. We still see an overall rate of CRS of 76%, but almost all of that was low grade, with only 4% grade 3 and no grade 4 or 5 CRS events. Neurotox occurred in a third of patients, but again, severe in only 4% with grade 3, no grade 4 or 5 neurotoxicity in this marginal zone study. There are some randomized trials ongoing for CAR T cells in the relapse refractory follicular lymphoma space, and we'll eagerly await that data. In my last couple of minutes, let me turn my attention to mantle cell lymphoma. This is Brexucell. Brexucell is very much like Axicell. It's the same construct, just with some purification of the CD19 CAR T cell product to remove contamination. These are 68 patients who were treated in the third line and later setting, all of whom had relapsed despite a prior BTK inhibitor. You can see they had a median of 3 prior lines of therapy. They had a maximum of 5 prior lines of therapy. They were capped in this study, and I'll come back to that in a moment. You can see the majority of these patients, 62%, were refractory to their prior BTK inhibitor, and a relatively small proportion, 17%, had a p53 mutation. The overall response rate is 93%. CRs were observed in a very encouraging 2/3 of patients, and those responses could be durable, with a median duration of response of 3 years. The progression-free survival for the overall population, you can see, was 25 months. Now, Brexucell, like Axicell, can be difficult in terms of toxicity. Here you can see CRS occurred in almost all patients at 91%, severe in 15%, any grade ICANS in 63%, and severe ICANS in a third of patients. And this can be really the most difficult toxicity that we now manage in our patients. It can take the longest to turn around, require a lot of long-term sustained steroids and the risks associated therein, leading to deterioration of functional status and rehab stays. We do now have real-world data for Brexucell in mantle cell lymphoma. This is CIBMTR data in nearly 500 patients. Slightly higher risk profile, up to 12 prior lines of therapy in this study, and 20% had p53 mutations. But once again, extraordinarily good results with an overall response rate of 91%, a CR rate of 82%, and what you can see at 1 year is 72% of responders remain in response, and 60% of patients remain progression-free at 1 year. Once again, Brexucell does have significant toxicity, and here severe CRS and neurotoxicity occurred in 11% and 30% of patients respectively. That leads to a non-trivial 12-month non-relapse mortality rate of 8%, which is something to keep in mind. We also have some real-world data from the French Descartes registry. And here, once again, heavily pretreated patients, 72% having a CR. The median progression-free survival in this very high-risk population, 30% had a p53 mutation. You can see the median progression-free survival in this real-world population was really 10 months. And once again, significant toxicity. A third of patients landed in an ICU, and 11% had non-relapse mortality. So I often favor Lizacell. We already heard about a more favorable safety profile for Lizacell and DLBCL. We see that as well in mantle cell lymphoma. Here you can see a very heavily pretreated patient, median of 3 prior lines. There is no maximum prior lines, unlike with the ZUMA-2 study, so patients with up to 11 prior lines have treated. And there were more p53 mutated patients than on ZUMA-2 at 23% on this study. You can see the CR rate was 72%. The median progression-free survival was 1 year. CRS occurred in 61% of patients, remarkably severe CRS in just 1%, any grade ICANS in just under a third of patients, severe in 9%, and that led to lower rates of ICU transfer at 6% on this study. So that sums up what we know for CAR T cells in follicular lymphoma, marginal zone lymphoma, and mantle cell lymphoma. Let's go to our cases. So the first case is a 68-year-old man with stage 4 follicular lymphoma, grade 2 with a Flippy score of 4. Patient has disseminated disease, bone marrow involvement, and B symptoms with a favorable performance status. Patient's medical history includes diabetes, had a prior MI, but does have a preserved ejection fraction. This patient received bendamustine rituximab as initial treatment for follicular lymphoma. This patient had a partial response, but progressed at 1.5 years. At that point, this patient received rituximab lenalidomide, R-squared, achieved a CR, but progressed just about 1 year later at 14 months, now has new adenopathy and cytopenias, and is in need of additional therapy. This patient goes to a third-line regimen with obinutuzumab-based chemotherapy, has a partial response, but progresses relatively quickly at less than 1 year. So let me start with Manali. You now have this patient who's had 3 prior lines of therapy, BR, R-squared, obinutuzumab chemotherapy. So the question for you, Manali, is what are you going to do now? Is it going to be a CAR? Is it going to be a bispecific? Or is it going to be something else?
I think this is a 68-year-old with POD24, as I see, and then subsequently double refractory, has had at least 3 prior lines of treatment. I would potentially go for CAR T-cell therapy over bispecific T-cell engagers. The 5-year data does show that 50% of patients are still in a remission. That's appealing in terms of the amount of time I could give him with CAR T-cell therapy over a CD20 bispecific T-cell engager.
And Jason, we know that now we have a newly, relatively recently approved regimen of R-squared plus epcoritamab for second-line and later follicular lymphoma. This patient already had R-squared, progressed 1 year and 2 months later. If you were going to choose a bispecific antibody for this patient, would you still consider R-squared epcoritamab as an option for this patient? Or would you think about a different combination or monotherapy with a bispecific?
I think we all are anticipating Dr. Phillips' presentation on that data set to see what we now should know about EPCO plus R-squared. But I would favor potentially using a single agent bispecific over going back to R-squared. This patient did have a complete response that lasted at least 1 year. This person had a real response. I have had multiple patients that I've re-challenged with lenalidomide and had subsequent responses. So it would depend in part, what was the experience of the patient? Did they have a terrible time on lenalidomide, or was it homeopathic side effects? I might consider adding it in, but probably would look at a single agent bispecific.
And I agree with Manali. I like CAR for this patient who's had POD24, not having very quick, very durable responses to subsequent lines. I think we've seen the most durable remissions long-term with the CAR T-cell products in multiply pretreated follicular lymphoma. Let's think about our next case, a 59-year-old man with follicular lymphoma. This patient gets R-CHOP, followed by rituximab maintenance as initial therapy, and then at relapse receives epcoritamab R-squared. Now, this patient, let's say they're still responding to epcoritamab R-squared, but Tycel, you always want to be thinking about what's going to be next. So if this patient who's progressing after frontline R-CHOP and then second-line epcoritamab R-squared, what would you be considering as third-line therapy after a bispecific combination?
So in a young patient like this in the third-line space, likely would be CAR T, but it also would depend on how long the remission duration is. Since epco R-squared is a fixed duration treatment, if there was a very prolonged remission, possible if the patient still expressed CD20 that you could re-challenge with this regimen, although we don't have any data on that as of yet.
So how long would that remission be for you to want to re-challenge with rituximab, lenalidomide, epcoritamab, say?
I mean, since I'm making it up at this point, ideally 24 months would be ideal. Ideally you would like something at least beyond 1 year to suggest that there was some benefit to rechallenge.
Let's go to our next case. 70-year-old man, a retired physician with extensive symptomatic mantle cell lymphoma. This patient gets bendamustine rituximab as initial treatment for mantle cell, responds but progresses within 2 years. This was back when we were still giving ibrutinib, and this patient got ibrutinib, did respond to the ibrutinib, but now has progression of disease on ibrutinib with symptomatic GI and nodal progression. My question for you, Dr. Brody, twofold. Here's first question, Josh. What are you going to do as your next line of therapy for this patient progressing on a BTK inhibitor? And second question, are you going to stop the BTK inhibitor while you're getting your ducks in a row, or are you going to continue it right up until that next line of treatment?
I'm going to answer the second question first, and then by the time I wrap around to the completion of that, I will have forgotten the first question. So we do want to, as a general rule with these mantle cells that can be explosive, we want to continue their BTK inhibitor until sort of the last possible second. And what that second is, how many half-lives of BTK inhibitor prior to the apheresis, we fight about that a little bit. Sometimes it can be 5 days, 2 weeks. But, you know, even though patients can be progressing through BTK inhibition, that ibrutinib or acalabrutinib or zanubrutinib can still be in the groove and still be slowing down BTK signaling. So we like to continue to the last possible second. Or in this case nowadays, possibly switch to a non-covalent BTK inhibitor as a debulking or as a bridge. So because, you know, this patient is headed towards CAR T therapy one way or the other, and we just want to get them there as safely as possible before their, you know, explosive disease prevents our leukapheresis. So yeah, we want to keep either their covalent BTK or non-covalent BTK around and probably on board to the last possible second before apheresis, and maybe even as bridging after apheresis, depending on how their disease kinetics are. And it's funny, I forgot the first question.
So the question is, what would you do? Would it be a CAR T cell, and if so, which one?
I really remembered it, but to pay back the prior,
I'm
I had
here
to say
for
that.
you.
Yeah. So this patient is headed towards CAR T. We're gonna, I think, learn in a little while from Tycel, not Tycel, but from Tycel that in fact we have upcoming wonderful data with bispecifics for mantle cell as well. But today this is going to be a CAR T patient, and I like to project equipoise about the different platforms. As you said, the lysocell safety data does look a lot better than the axicell safety data. So I think this patient is moving towards lysocell. Let's also keep in mind that either debulking or bridging or both may be very important for these folks. That could be ibrutinib, it could be non-covalent BTK, or now it could be sonrotoclax or even off-label venetoclax as well.
Yeah, so how about that, Manali? These can be challenging patients to bridge. What are you reaching for in mantle cell lymphoma? And is sonrotoclax, recently FDA approved for mantle cell, going to enter your bridging armamentarium?
Yeah, I'm so glad that the toolkit for bridging is increasing. I would agree with Dr. Brody that please do not stop the ibrutinibs until you have the next drug on hand to prevent massive tumor flare. So keep the BTK going. I typically use pirtobrutinib, the non-covalent BTK inhibitor, and then keep it going until we get to CAR T cell therapy. I also utilize post-apheresis obinutuzumab to be able to induce a little bit of peripheral debulking. I have seen in that scenario that CARs may actually have less ICANS. So that's something I do use. And with regards to sonrotoclax, I am actually looking forward to having it in clinic. It is approved, but not yet available. So as soon as it is available, I think for our patients, it's a great option. The big question then is, could we then exhaust the non-covalent BTK inhibitor, reserve CAR for fourth line, and then use sonrotoclax as a bridging to get to CAR, would be the question. Sonrotoclax obviously has to be ramped up in a different way, so that would be something that we'd all have to learn in clinic.
Okay. And the next discussion question is actually going to be our teaser right in to our next module. So let's bring up Dr. Phillips to answer that very question for us. Is there a role for bispecifics in mantle cell as well as in low-grade lymphomas? Tycel.
All right, so my title says it all. So low grade and intermediate, because MCO doesn't fit in low grade. So obviously, as we discussed, follicular lymphoma is a very unique situation. We do have 3 CAR T agents approved, which were discussed. And we do have small molecules, specifically the Rosewood study with zanubrutinib obinutuzumab. And we historically had tazemetostat, so we'll have a brief moment of silence for tazemetostat and the PI3 kinase inhibitors. Apparently the cemeteries are getting bigger. So if we look at our bispecific antibodies, Dr. Westin has already elucidated, we currently have 4 access within, globally, 3 within the United States, but 2 specifically for low-grade lymphoma, mosunetuzumab and epcoritamab, and we've already discussed the structure of these antibodies. So mosunetuzumab is an IV formulation or subcutaneous formulation. So with the IV formulation, it's given 1 milligram, 2 milligrams, 60, 60, then 30 milligrams for either 8 or 17 cycles based on attainment of a complete response. With the subcutaneous formulation, it is 5 milligrams, 45 milligrams, and 45 milligrams. And then, again, every 3 weeks until for 8, it's either cycle 8 or 17 based on attainment of a complete response. Now, again, there has been a big push towards subcutaneous formulations versus IV formulations. I will say the benefit is less chair time, but again, the negative of that is an injection site reaction, which you don't necessarily have to worry about with an IV formulation. And given most of our patients would have already had an IV formulation of something prior, I mean, again, this is a discussion to have based on patient preference. So as we discussed before, these agents are effective as we see a high overall response rate with mosunetuzumab, complete response rate of 60%. As we see on quote-unquote high-risk subsets, there does not appear to be a difference. So again, across the board, it appears that this bispecific antibody is quite effective in this patient population. If we look at the durability of response, I mean, the 24-month duration of response is 53%, duration of complete response 63%, 24-month PFS 48%, so again, slightly less than what we see with CAR T-cell therapy. Time to next treatment 56%, and overall survival 87%. And again, we know with patients in a complete response, the durability of responses are quite durable. And again, a question that we don't necessarily have a complete answer to about retreatment in these patients, but the assumption is that, again, if a patient still expresses CD20, mosunetuzumab is something you can re-challenge a patient with. So the biggest claim to fame with mosunetuzumab is its safety. I mean, if you can see the rates of cytokine release syndrome in this U-shaped platform is quite impressive. Rates of CRS, mostly grade 1, we see with cycle 1, day 1, and again at the first full dose of 60 milligrams on cycle 1, day 15. And then we see negligible rates of CRS thereafter. ICANS is really not something we typically see with the CD20, CD3 bispecifics. And so again, based on age or frailty, we can pretty much give mosunetuzumab across the board in this patient population. As we will discuss, we do know B-cell depletion is an issue, hypergammaglobulinemia with these treatments. And so again, infections are an ongoing and long-lasting concern until B-cell recovery and recovery of the immunoglobulins with these treatments, which we do know will happen after cessation of this treatment. So epcoritamab is a little bit different. It is a subcutaneous formulation. It is given at the dose of 0.16, 0.8. Then initially it was 48. Due to safety, they did add a third step-up dosing of 3 milligrams. Corticosteroids are given for the first 4 days of step-up dosing. Thereafter, it's given weekly through cycle 3, every other week through cycle 9, and then monthly until the cows come home. Again, this is a little bit of a difference between epcoritamab and mosunetuzumab in the patient population. Again, finite versus indefinite therapy. Very similar to what we see with mosunetuzumab, the CR rate and overall response rate is very impressive in this patient population. So again, highly effective treatment. Again, most of these patients are getting a complete response with this therapy. If we look at adverse events, again, with the third step-up dosing, we do see that the rates of cytokine release syndrome with epcoritamab mirror what we see with mosunetuzumab. And so a little bit different from what we know in a large cell lymphoma patient population. There is no recommendation for hospitalization with epcoritamab for patients with follicular lymphoma. So you can give this as a completely outpatient regimen without necessarily having concern for having to hospitalize the patient. Now, again, the corticosteroids throughout the step-up dosing is a recommendation and requirement. And again, because of the steroids, patients likely to have prophylaxis with HSV prophylaxis with acyclovir, and then PJP prophylaxis, usually with Bactrim or Mapron for this patient population. So I'll briefly show the AUGMENT study just to lead us into the EPCOR FL1 study, which is the randomized study of epcoritamab plus R squared versus R squared in a patient population that is a little bit different from what we saw from the original AUGMENT study. In this situation, there's a high proportion of patients who are resistant to rituximab, this was an exclusion criteria for the original AUGMENT study. So as we can see, it is a very high response rate, very durable and impressive early look at the progression-free survival in this patient population. And I will say, again, looking at the safety signal, again, this mirrors exactly what we saw with epcoritamab, especially when you take into account the third step-up dosing. So the only major change we see with the addition of epcoritamab in the second-line setting in combination with R-squared is we do see a higher rate of neutropenia. There is a higher rate of infection, which has been sort of raised up in other discussions when we consider some of the other sort of second-line options, R-squared by itself or tafasitamab R-squared. But again, if we look at the durability of response, at least in this early readout, and the time to next treatment with this regimen, it does appear fairly impressive. So again, in a situation where you have a highly aggressive follicular lymphoma patient you are concerned about, this regimen could be a fairly reasonable option in this situation, or CAR-T as was discussed previously. So other studies looking at bispecifics and lenalidomide, we have the Celestimo study, which the difference here is that there is no rituximab given, so it's lenalidomide and mosunetuzumab. In this study, this is IV mosunetuzumab, and the lenalidomide is only started with the start of cycle 2, so after the completion of most of the step-up dosing for the mosunetuzumab. So if we look here at the patients refractory to CD20 antibodies, we see it's about 40%. And just for comparison's sake, we will see with the EPCOR FL1 study, it is a very similar patient population, so the results are fairly comparable, even though, again, we should not do cross-trial comparison. So, again, looking at safety and response, you see the overall response rate is fairly comparable to the epcoritamab study. Safety-wise, mostly grade 1, grade 2. There are a few episodes of grade 3 CRS noted. And again, as we discussed with the epcoritamab and R-squared study, infections are the big concern with this combination, as well as GI side effects from the lenalidomide. As you can see, the most common adverse events in this situation were fatigue, rash, and constipation, which really sounds like the adverse event profile of lenalidomide for our patients. So here's a list of ongoing studies looking at the combination of a bispecific in the frontline or relapsed refractory setting. The only correction there is if you look at the first phase 3 study, the Morning Light study is actually in untreated patients, and it is compared to chemoimmunotherapy. Again, we have the S23008, which is a randomized phase study with mosunetuzumab versus rituximab in patients who do not meet GELF criteria, conducted by the U.S. cooperative groups. We have odronextamab versus chemoimmunotherapy in Olympia 1. We have Odro R-squared in relapsed refractory patients, EPO R-squared in the frontline setting versus chemoimmunotherapy, and then mosunetuzumab again in a second-line setting, the Marsan study. So, turning our attention to mantle cell lymphoma, we did have an update from the 179 study by Dr. Karimi. So this is the situation. We do know mantle cell lymphoma, especially those BTK refractory, is a difficult patient population. Unfortunately, CAR-T cell therapy is unlikely to be curative in mantle cell lymphoma, a little bit different from what we see in large cell lymphoma. And while we did talk about these other options, such as portabrutinib and sonrotoclax, these are likely to be bridging therapies. Again, only a small minority of these patients will have durable responses. And again, the resistance pattern for mantle cell lymphoma is far different from CLL. So again, the mechanism of action of pirtobrutinib really does not explain and overcome the resistance mechanisms for the vast majority of patients with mantle cell lymphoma, and is best served as a bridge option. We do have information on Mosunpola, which looks very impressive with the early readout, but again, we need more longer follow-up for the study to sort of get the durability of response in this patient population. So, turning our attention to the mantle cell lymphoma patient, again, we do know it was high overall response rate and complete response rate in this patient population with complete response rates around 70%. And as you can see in this situation, with those with a complete response, there's some durability of response. Now, this was conducted through the COVID pandemic, and so there are some COVID events. So censoring those events do indicate that at least disease-specific survival specifically, you see the median duration of response of 40.8 months in those with prior BTK inhibitors. BTK-naive patients, 46.5 months, suggesting that this can be a durable treatment option for this patient population. Looking at the progression-free survival, again, this suggests, again, some durability of response, especially if we look at the patients with BTK-naive with a progression of response, look at 50 months. But even in those, again, with prior BTK exposure, if we could do COVID censoring, the PFS is 16.8 months, which, again, fares very favorably compared to some of the other options we discussed, even including CAR-T cell therapy. Overall survival, again, it suggests that these patients are able to have some durability of response, survivability, which is very important in a non-curative treatment. Again, longer follow will hopefully suggest that these patients will maintain these remissions for a longer time. So looking at landmark analysis, those who actually have a complete response at the end of treatment, you can see very durability of the progression-free survival curve. And specifically looking at those with MRD analysis, we do see that there is some durability, especially looking at end of treatment. The bigger question will be the CRs at cycle 3. What is the events in these patients who are undetectable MRD? If they are not diseased, it possibly suggests that maybe glofitamab does not have to be given for 12 cycles if some of these durable responses are obtained, especially if patients are UMRD after cycle 3. To the bigger point, we do see some B-cell recovery after stopping this medication. So again, this is 8 months of treatment. So about 12 to 24 months, we have some B-cell recovery, which again reduces the risk of infection, which is very important with bispecific antibodies. So survatimab with the phase 1 follicular lymphoma study. This again is a very study looking at the CD19 bispecific antibody. Again, a little bit different from what we do with the CD20. Again, targeting a different epitope. Again, it's IV administered. Again, with a step-up dosing that was adjusted a bit due to some adverse events in this patient population. But with a more two-step-up dosing regimen, as we will see, there's a reduction in some of the adverse events with survatimab in this patient population. The more impressive thing is the high overall response rate. Again, with the full dose of 15 milligrams, you see an overall response rate of 100% in this patient population. And again, of those with the MRD analysis, 95% were MRD undetectable in this patient population. And this is being further studied in a phase 3 study, Soundtrack F1. It's a global randomized study of survatimab plus rituximab in patients with previously untreated high tumor burden follicular lymphoma. So we will highly await the completion of this clinical trial as we move forward. So in conclusion, bispecifics work in follicular lymphoma and they work in mantle cell lymphoma. And a nice little curveball in there with slides that I did not include.
Thank you, Tycel. We appreciate you knocking curveballs out of the park. As always, let's go to our discussion cases with a 60-year-old man with follicular lymphoma. This 6-year-old gentleman gets bendamustine rituximab as initial therapy, progresses 6 months into rituximab maintenance, and is switched to temporizing R-squared while a biopsy is obtained. That biopsy shows no transformation to DLBCL. So we now have a 60-year-old man progressing on rituximab maintenance after BR. R-square has been started. And Josh, based on the data that you've just seen, would you be adding in epcoritamab?
Yeah, it's a novel approach to use temporizing R-squared during a biopsy. I haven't tried that yet, but if assuming that they are responding okay to the R-squared and tolerating it reasonably well, let me say this. In this highest risk patient, blowing right through Arbenda, progressing right after Arbenda, that's really bad. This is, amongst the worst POD24 types of patients. And, Tycel showed that gigantic space between R-squared plus EPCOR versus R-squared alone. And the R-squared people just didn't do as well as the augment. They were going straight down in progression. They were progressing quickly. So I would say unquestionably in this patient, I would add the epcoritamab on top of the temporizing R-squared.
So, Jason, historically in my practice, I've done chemoimmunotherapy frontline. I've gone to R-squared second line. We now have not only the EPCOR study, we've got the tafasitamab R-squared study. We've got 2 randomized trials showing that a Len-R triplet is beneficial. How are you thinking about choosing between those options?
Yeah, I think it's great to have a lot of options, but it's back to the same question about which bispecific antibody or which CAR T-cell. It's hard to compare across these studies when you've got great data in randomized phase 3 trials showing a benefit over a common control arm. TAF-R squared is attractive, and it has a favorable toxicity profile. We didn't go through all of the data here tonight, but it is something that is an option to consider for your patients. R squared by itself is not a bad option. In that option, although it lost in those trials, people live a long time with follicular lymphoma. And so adding in antibodies, adding in triplets is a consideration for some patients. And then for this particular patient that progressed quickly, I agree with Dr. Brody, very high risk. I would consider adding in either TAFA or EPCO. But in somebody who had less aggressive disease, R squared and saving your bispecific antibody for a later date might be reasonable to consider.
Absolutely. Let's go to another case. This is an octogenarian, 80-year-old woman, again, follicular lymphoma. Again, BR as initial treatment, followed by progression, gets the tafasitamab R squared regimen as second line. At this point, this patient has an ECOG performance status of 2. She's a frail 80-year-old, and always you're thinking, what's next, Manali? So this patient's doing okay on TAFA R squared. I'm assuming she's requiring some dose reductions of the lenalidomide. But the question then is, given that we no longer have tazemetostat, may it rest in peace, what would you be thinking about in the next line of therapy, and would a bispecific be appropriate for this patient?
Yeah, the next line of therapy for an 80-year-old frail ECOG2 patient after having progressed on BR and TAF-R square would be twofold. One could either do zanubrutinib plus obinutuzumab, or one could go for bispecific T-cell engagers. I would probably favor the latter because there is a durable complete response rate now at 5 years. I would probably favor bispecific T-cell engagers in this case at time of progression. And between the two, Mosin and EPCO, I do think that the Mosin data at 5 years is quite good. So I would probably do a time-limited subcute option with Mosin for her at progression.
So, Tycel, I asked you earlier to choose between bispecifics and a different indication, so I might as well be consistent. Manali just put her nickel down, says she likes time-limited mosunetuzumab as opposed to continuous epcoritamab. How are you choosing?
Yeah, I would agree. I think in this situation, I think mosunetuzumab would be the preference because, again, don't really have to think much. CR at 8, I stop. CR at 17, I stop. I don't have to guess when to actually stop the bispecific. So efficacy-wise, I don't think there's a difference. It's just a simple fact that there's more data with stopping this treatment, which in an 80-year-old who's already had BR, I mean, the concern would be continuous treatment would lead to more infections.
Yeah, and a bit more convenient schedule for every 3-week Mosin as opposed to initially weekly epcoritamab, which might be tricky for an older, frailer patient to make all those clinic visits. All right, let's think about a 78-year-old patient, Josh. This patient has follicular lymphoma, an excellent performance status. Previously, it had weekly rituximab, then had gotten bendamustine rituximab, and then had gotten R squared. This patient is progressing again, needs a 4th line of therapy. And so the question is, what would you give, and would it include R squared?
Yeah, it's a great question because we have, I would say, 0 data about it. R squared was an exclusion criteria in all of the trials combining R squared with bispecifics. And, you know, even though there's never going to be a trial, doesn't mean that there can't be a real-world experience at some point. So, you know, we have a precedent of we used to have a precedent of retrying old things. Now we have so many things, it hardly ever comes up. We always switch to something new. But let's keep an open mind. If someone had an R squared that they tolerated, as Jason was saying before, we need to not just know how effective it was, but how well tolerated it was. They tolerated it great, and they had a 3-year remission after their R squared. Sure, I would keep an open mind about it. But really, quite honestly, you know, that person's going to be 81 at that point, and CD20 by CD3 bispecific monotherapy would be pretty reasonable.
Great. Let's take let me go with a case from the audience, and I'll come back to you, Jason. This is a 70-year-old man with grade 2 follicular lymphoma, classic follicular lymphoma, initially followed for 2 years without therapy. Comorbidities include hypertension, diabetes, gets frontline therapy with bendamustine rituximab, achieves a CR which lasts for 5 years. Patient now relapses, gets R-Len, rituximab squared, as second-line therapy, relapses a year and a half later. Josh started mosunetuzumab on this patient, and now we're thinking, what's next? So this patient's now getting their Mosun. They've already had R squared and BR. What are you thinking next in this patient who's now, let's say, 74 years old?
And the patient is progressing on Mosun or is still in response to Mosun?
We're gonna we don't have that information, so let's say they're progressing on Mosun.
Okay, so your scan says that Mosun is not working. That's a situation where I'm beginning to consider CAR T-cell therapy as a potential option. We heard about BTK inhibitors as a potential therapy, but for somebody that's having an accelerating course of progression, they had an initial great response to bendamustine, 5 years, but a much shorter response to R squared of a year, and now progressing on bispecific antibodies. This is starting to smell a bit more like transformation, that this person's disease has got an accelerating cadence. Our chemotherapy would be an option for that patient. They've had relatively light amount of chemotherapy, but I would start looking towards a CAR T-cell in somebody 70 years old is relatively young for a follicular lymphoma patient who's got that progressive disease. So that would be top of my mind, is to screen the patient for clinical trials or CAR T cells.
Right. And what would you think about as a bridging option for that patient?
I think you could likely do any of the above for that patient. They probably would respond temporarily to anything you would try.
Right. We've got another case from our online audience. Josh, listen to this one. This is a 67-year-old man with relapsed follicular lymphoma, grade 1-2, stages 3A. This patient has chronic Hep B, but on antiviral prophylaxis with a negative PCR. This patient was previously treated with R-CHOP as initial therapy, followed by R-squared, had progression after second-line R-squared, and gets mosunetuzumab. This patient developed grade 1 CRS during step-up dosing, subsequently tolerated it well, and now in a complete metabolic remission, stopping the fixed-duration mosunetuzumab. So for patients who achieve a CR with fixed-duration mosunetuzumab, generally, what duration of treatment and long-term monitoring are you recommending after completion of that therapy?
As Tycel mentioned a moment ago, we can sometimes stop the mosun early depending on when they get their CR. But let's just say that they got their CR, they got a PR and then a CR. They're going to, finish their complete time-limited mosunetuzumab, and monitoring both during and thereafter. This person has had a fair amount of therapy. I wasn't quite clear on the density when they got their front line and second line, but they've had a lot of therapy, so they can have all types of different versions of immunosuppressions. They're going to have some transient B-cell aplasia, and they may have some hypogammaglobulinemia, and they can even have both neutropenia during therapy. And just like we had delayed onset neutropenia with rituximab, we don't talk too much about it, but the same thing happens with CD20 bispecifics as well. So yeah, this person needs immunoglobulin IgG monitoring during and after therapy. The frequency of it depends on where their IgG starts when you first check them. If they're 900 when you first met them, they don't need weekly checks. If they're 401 when you first meet them, then they need more frequent IgG monitoring. They need CBCs, but when they're done with their therapy, we do them monthly, then Q3 month, and depending again on where they started. Let me just say, because this is going to maybe be a segue to how to safely treat these patients, in addition to all that monitoring, they need the health care that we all need, which is to get the vaccinations we're supposed to. I hope I'm allowed to talk about vaccinations.
We can. It's a safe space, Dr.
It's a safe
Brody.
space. They need all of those things because infections beyond all of these dramatic side effects, CRS, ICONS, et cetera, are still the main toxicity of all of these therapies. So they need their vaccinations and they need their monitoring.
Last question on a case quickly to Dr. Kamdar. Manali, 70-year-old woman with follicular lymphoma, excellent performance status, had prior treatment with rituximab, BR and R squared. What would you offer this patient? Would you go TAFA R squared? Would you give EPCO R squared? Or would you do something different?
I would do something different. I think in a patient who has had 3 prior lines of treatment, including an alkylator, as well as R-square. I don't know the cadence of the relapse, so I assume it's pretty fast. And if that's the case, my intent would be to take the patient to CAR T-cell therapy. However, if that is not an option, say, for example, because of caregiver issues, then I would not hesitate to pivot to a CD20 bispecific T-cell engager, provided the tumor biopsy still expresses CD20.
Great. And let's go to our final module. For this module, we're going to invite Dr. Brody up. Josh is going to talk to us about tolerability considerations with CAR T cells and bispecific antibodies.
Professor Abramson, thank you so much. I have to say all the other speakers got to talk about all the exciting, wonderful things we do for patients and show you the beautiful trial data, all these complete remissions, these durable remissions, these cures in some context. They got to show you all the good news. I'm going to talk a little bit about the bad news. Nonetheless, even if I don't get to show all of the wonderful responses, this talk will still be, somewhat less sexy, but very important. In that way, a lot like Dr. Abramson. So I'm grateful for the opportunity. Thank you so much. Tolerability is something that we think about because either we are treating these patients throughout the course of their immunotherapy with these T-cell redirecting therapies, or we are re-inheriting them after, for example, CAR T, if they were transferred to the academic center and then come back to us. So either way, thinking about the tolerance of these therapies is important. Much of this data was shown already, so I will not belabor the details, but you can see a few things here. First of all, that for all of these things that we talk about, even high-grade CRS and high-grade icons, the majority of patients do not get those high-grade adverse events. And still, you can see some trends between the different platforms. And what you don't quite see here, but I tried to imply it with the year of the publications, is overall, we've probably also gotten better at time at minimizing these adverse events. As you see the trends in high-grade CRS and high-grade icons going down as the page goes down vertically. Cytokine release syndrome can be extremely dramatic. I mean, really, this would look like, we sometimes call this sepsis without the sepsis. And certainly if the patient were to show up in the ER without a good infrastructure and established understanding of who those patients are, the ER is going to treat them like sepsis. We do not go into details into the grading, but it is actually fairly simple. Fever alone we call grade 1 CRS. And therefore, we probably over-dramatize this because you could say we all got grade 1 CRS after our flu vaccine, but we didn't make a big deal about it by giving it a fancy name. The point there is that although we talk a lot about CRS, grade 1 CRS is a nothing. It's go home and see you later. So let's not all think that all CRS is a big deal. High-grade CRS, grade 3 and above, is a big deal. That's what lands people in the ICU. As you saw, thankfully, those numbers are, the high-grade CRS numbers are extremely low with bispecifics across the board for all of them, and low and getting lower with CAR T cells over time. Icons, we give it this long name, I won't even say it, but we can sometimes just call it either neurotoxicity or encephalopathy. Getting better with lower incidences of high-grade icons in CAR T. And as was said by actually, I think, a couple of the panelists, it's barely a thing in bispecific antibody. I have to say that although you'll see all of the bispecific antibody data with these small numbers of icons, we have to be a little thoughtful if they were all appropriately categorized as icons, because if someone got grade 2 CRS with a fever of 104, that person will act wacky, and sometimes they might get labeled as icons. It really should be very specifically a distinct syndrome with its own kinetics and envelope. If it's concurrent with CRS, we have to be very skeptical if that was actually real icons. So maybe even the low numbers we see with the bispecifics might be even actually lower if we really separate out the CRS and the icons. These kinds of simple printouts are actually very available online, and you can actually, I think, get some of them with searching up Dr. Crombie's recommendations for how to manage these patients, or some very similar printouts. And these things are actually very helpful for our physician extenders, our nurses and nurse practitioners, just so they, at a quick glance, without memorizing a lot of details, can quickly say, this patient has this grade CRS, and that way we can make an easy algorithm. This patient stays at home and gets acetaminophen, ibuprofen, and fluids, Gatorade water or whatever. Gatorade is a brand name, so I hope I won't get in trouble for mentioning a brand name. Let's say electrolyte fluids, and these patients need to come in. But grade 1 CRS and probably much of grade 2 CRS can be managed at home depending on the social support system of the patient. So this is an exciting advance from now coming up on a year ago. There was a REMS requirement for CAR T cells very broadly. You guys are familiar with these REMS requirements. We've seen them for lenalidomide and many other medicines. I won't go into the details of the requirement. The important news is that the requirement was lifted a year ago. And the reason is because we now have so much both clinical trial experience, but also real-world data showing that CAR T, broadly speaking, can be well managed not only at these highest throughput academic centers, but many centers. And the reason part of this was practical is that, as was mentioned, I think, by Dr. Kamdar, that we kind of know that many patients that should be showing up for second-line DLBCL CAR T are not showing up. And therefore, we want to make these more accessible. That was the rationale for getting rid of the REMS requirement. And then the consequence of this is that more centers should be able to make CAR T available for their patients. Still, the REMS was not the only obstacle. We have to develop infrastructure and develop experience at some of the smaller centers, but this is very doable. And if your nearest CAR T center is 5 hours away, that's an indication that now we are encouraging as many centers as possible to make this be locally available. Okay, so we talked about CRS and icons, and these are the dramatic again, maybe cinematic side effects that we see. They are a big deal. They happen suddenly, and they are exciting. And if you were going to be on a TV show, you'd put CRS on there because it will be an exciting thing where they were on the death's door and we got them some dexamethasone tocilizumab and saved their lives. And still, these are not the most important things associated with either CAR T or any other T-cell redirecting therapy like bispecifics. The cytopenias that can last much longer and then the infections they give rise to are really the big deal thing. So I want to emphasize that. We can even make some reasonable guesses as to which patients are going to have the most prolonged cytopenias. And one great trick for that is this simple score called the hematotox score. As you can see there, it's a very simple 5-point scale of lab tests that are routinely obtained anyway, CBC and 2 inflammatory markers, the CRP and the ferritin. You don't have to memorize that. If you can remember the word hematotox, to put that into Google or any other browser. It doesn't have to be Google. Other search engines will work as well. I don't want to pick a brand and go with it. And you can find this hematotox algorithm. I listed the website there as well. And you simply put in these things, and you can see that people with a high hematotox score have great risk of prolonged cytopenias, and with a low score, a much lower risk. Would this be actionable? It might sometimes be actionable if you were actually deciding between therapy A and B. Some patients absolutely need CAR T, so this is just informative for them, maybe not actionable, but it can be actionable in some contexts. And again, just to show, I showed the cytopenias. This is an amazingly powerful predictor for who are going to get late infections. Well, I should say infections. They can be over the first 90 days and also and later as well. But you can see that a low hematotox score, in fact, these CAR T-cell therapies pretty well tolerated in terms of high-grade infection. High hematotox score, a big deal. And as I say, this may not be actionable, just predictive, but you can see the actionable thing right there, even beyond hematotox score. Patients that did not get prophylactic antibiotics for, again, we don't have to talk about the exact duration of it, but they had a much higher risk. You can see a tripling of risk of high-grade infections over time in patients that did not get appropriate prophylactic antibiotics after their CAR T-cell therapy. And, the thing that comes from bad infections is non-relapse mortality. And you can see hematotox score is a very powerful predictor. Again, a quadrupling of risk. In the medium time points where there's more censorship of data, a quadrupling of risk of high hematotox score versus low hematotox score. So this is a thing we can simply eyeball in our patients to predict how it's going to go, and also relates to overall survival beyond just non-relapse mortality. This is a bit of data and a little bit granular, just looking at many, many prior trials, both clinical trials and retrospective real-world analyses, showing that we see mostly bacterial infections. The pink there, the pink bubbles are bacterial infections, the green are viral, and you see some even fungal infections underneath that. And you can see that with CD19 CAR T, it is comparable to what we see with BCMA CAR T. I'll say overall comparable. Good. Let me just again hammer home the point that if you look at people that did die not of relapse, non-relapse mortality, the great majority of them, and I say majority because it's just over 50, but way more than all the other individual contributors to non-relapse mortality, are infections. All that navy blue there, I think it may be royal blue, maybe the navy blue. Those are all infections, and as you can hear, high-grade infections. We can break them down by type, and this data certainly overlapped with a lot of bad times in the pandemic, but again, only a minority of these were documented COVID-19. So all types of infections, bacterial, fungal, viral, and otherwise. So infections are a big deal and something that we can intervene or prevent. So that's very important. And some of these other things that we talk about, you can see that you barely even see a pizza slice there for CRS or ICON. Those are not the things that kill most of the patients that die. Infections are. And we put a little expansion of the pizza pie slice of secondary cancers. We have a few patients getting secondary AML and MDS. Those are, I would guess, more likely from their other therapies, not from their CAR T, and a few other rare cancers as well. And in fact, just as we saw more acute side effects with mantle cell lymphoma, we see more of these infections as well. And then we have this rare side effect of CAR T-cell related T-cell lymphomas. I won't talk too much about it because you can see if they're so rare they show up in the New England Journal of Medicine, they must be uncommon. And we don't know if this has happened in 30 out of the 30,000 patients that have received CAR T. We don't know the real numerator, but it is a tiny fraction compared to infections, something that we can intervene upon. I think that I will, for the sake of time, pause there. Oh, sorry, let me make this one last point because this is a critical one. We do have a lot of community oncology buddies who, started using bispecifics when they were first approved for multiple myeloma and probably got some perception that the high-grade infection rates are quite high with bispecifics. They are pretty high for multiple myeloma, specifically, I should say, for BCMA-targeted bispecifics. But really, they are, half or a third with CD20 bispecifics, and we'll probably get similar data for CD19 bispecifics as well. So let's not have a take-home message of high-grade infections are common with bispecifics. They are much less with lymphoma bispecifics than with myeloma bispecifics. And I'll pause there so we can move on to discussion questions.
Thank you, Josh. Let's go to our cases from our general medical oncologist. We are going to launch off with a 71-year-old woman with follicular lymphoma with bulky symptomatic nodal disease. She's had frequent recurrent infections in the setting of COPD. Prior treatments include bendamustine rituximab. It says weekly here. Please don't give bendamustine rituximab weekly. That's a typo. It's a Q28-day regimen. Weekly would not be good for T cells or anything else. After progressing on bendamustine rituximab, got R-squared and relapsed again and is now getting a bispecific antibody and responding. So Tycel, what would you say are your current best practices? This patient is already having recurrent infections, is a high-risk substrate with COPD, is multiply pretreated, including bendamustine, now on a bispecific. How are you using prophylaxis in these patients, and how are you giving IVIG?
So, IVIG question in patients with recurrent infections, I'm usually generally trying to keep IgG levels normal versus aiming for just above 400 in those situations. Then also monitoring IgG subtypes and specifically paying special attention to IgG3, which has the shortest half-life and something that typically needs to be replaced in some of these patients. As far as other sort of prophylactic medications, I generally have these patients on acyclovir, and if I'm using epcoritamab because of the steroid usage, I will likely start these patients on PJP prophy, and that is usually my management strategy for these patients.
Jason, and our myeloma colleagues typically are giving IVIG really quite routinely based on just the number. This patient is already having recurrent infections, but I wonder in your practice, do you reserve starting IVIG in general for a patient who's having severe and recurrent infections, or are you routinely starting it for hypogammaglobulinemia without infections?
It depends a bit on the patient. If somebody's frail, I am aggressive at managing IVIG therapy for hypogammaglobulinemia. I think it's an important issue that if we don't check IG levels, we don't ever pick up. So I do want to highlight Dr. Brody's comments about this as a significant issue. It's less common, though, in non-Hodgkin lymphomas to see infections with bispecific antibodies than what we saw for our myeloma colleagues. And so I do think it's important, but it's not something that I want to panic the patients over or that I bring the patient in all the time to check levels. It's something that their baseline level, their fitness, I customize how aggressive I am.
And Josh, you've told us about the side effects and you've been involved in some bispecific studies. And, there's this trend that's emerged among myeloma patients where they're getting prophylactic tocilizumab, something that we typically haven't done to prevent CRS with bispecific antibodies. Is that something that you've seen or considered doing in patients with lymphoma, or is that a myeloma-only type scenario?
That's a myeloma-only type scenario with maybe some rare exceptions. But again, in FL, DLBCL, we see the high-grade CRS is low single digits or 0% in large trials for follicular, subcutaneous, epcoritamab at the right dosing. So why would we give 100 patients toci when 1 or 2 might need it? 98 of them didn't need to get it. So mantle cell lymphoma, as Tycel was showing, much higher risks of CRS, and even there, not a priori toci, but I've seen a couple examples of it might be appropriate for some mantle cell.
Got it. Let's go to our next case. This is a 72-year-old man with a blastoid variant mantle cell and a P53 mutation. Manali, this is a high-risk patient. They get R-CHOP acalabrutinib as initial therapy with no response. They get that emergent fractionated cyclophosphamide and rituximab with radiation followed by CAR T cells. So fairly aggressive bridging strategy with combined modality therapy, having progressed on a BTK inhibitor, and goes right into CAR and has a dramatic CR by PET. They did have grade 2 CRS. They had grade 1 ICANS. We just heard Josh allude this a second ago. It's interesting that not all CARs are created the same and not all diseases are created the same. Do you think there's more CRS and ICANS in mantle cell lymphoma CAR patients versus other histologies?
Yes, I think there is more CRS and ICANS, especially ICANS, in mantle cell versus other histologies, and it may have to do with peripheral blood involvement with mantle cell. We also see the same theme with ICANS in CLL. So I think it probably is more subtype specific.
And do you think that's a tumor burden issue, marrow disease, circulating disease, so common?
I think circulating disease, marrow disease.
And Manali, just continuing on that, how are you monitoring these mantle cell lymphoma patients who are at higher risk? Are you doing anything different than you do in large cell lymphoma?
Yeah, I think it depends on which product I'm choosing. I try to debulk them as much as I can. And if I'm choosing a Brexicel over Lysocell especially, and if someone has a lot of proliferative mantle cell, leukemic involvement, marrow disease, I typically have given them prophylactic steroids. That has been one strategy to limit CRS ICANS. I'm actually surprised that this patient who has blastoid anti-p53 only had grade 1 ICANS. I would have actually imagined this patient to have a slightly higher grade ICANS, but happy for the patient.
Thanks, Dr. Kamdar. And thank you for pronouncing ICANS. I'm not a fan of the icons.
Well,
Dr. Kamdar is an icon. ICANS is a toxicity. Jason, this is a high-risk mantle cell lymphoma patient. They've got a p53 mutation. We didn't really see plateaus on those curves in mantle cell with CAR T, and this is a really high-risk patient. So a question for you. You've got this patient. Is there a role for maintenance therapy? Or to come back to a question I asked you earlier, is this, let's say this patient wasn't 72, but 52 or 62, would you think about an allo for a high-risk mantle cell patient?
Yeah, I think especially in mantle cell, this is a disease that has a higher risk of late relapse. And for somebody that has blastoid and TP53, I am very concerned this is a response that may not be durable, and I would be thinking about additional options. There really are no good data to suggest maintenance post-CAR T-cell is something that we should be using uniformly. If this person hadn't had prior BTK, I would think that could be reasonable to consider as something that may not be too toxic to the CAR T-cells themselves. But this person had no response to that. So I would not revisit BTK inhibitor therapy in this person. I do think allogeneic transplant would be reasonable to consider.
Let's go to our next case. This is a 50-year-old woman with stage 4 grade 2 follicular lymphoma, diagnosed 2012, had BR as initial treatment, progressed after 2 years, got R-CHOP and R maintenance as second-line therapy, had a really nice remission that lasted many years, then subsequently progressed all the way in 2023, got Mosun as third-line therapy, but then had recurrent admissions for hematuria. Cystoscopy showed hemorrhagic cystitis. Josh, I've never heard of hemorrhagic cystitis associated with Mosun.
Well, Jeremy, you're quite young, so there's probably a lot of things you haven't heard of yet. But give it time, and you'll be exposed to more life experiences. And I'll be honest, I honestly, before I heard about this case, had certainly not heard of any relationship between hemorrhagic cystitis and any CD20 bispecific. So, I think we might have chatted briefly about this. The more likely possibility here is that we are some rare viral infections, and BK virus and adenovirus are some that are associated with hemorrhagic cystitis. I think maybe this person was just thinking anti-lymphoma therapy because we also have some precedent of some old alkylators which, can be associated with hemorrhagic cystitis. But in this case, the patient may not only have the immunocompromise of the recent Benda and the R-CHOP and the CD20 bispecific, but they may have a priori immunocompromise even before that. So I would say this person needs to get, an infectious disease consultation beyond the urology consultation to go look for these rare viral-associated cystidities. That's the plural.
a good reminder to think about opportunistic type infections for these heavily immunocompromised patients. And then, Tycel, you're a guru for bispecifics. Any pearls or uncommon toxicities that you want to leave us with to be aware of?
I think no. I mean, I think Dr. Brody hit the nail on the head. I mean, the biggest thing is just some of these rare viral infections that we can see with long-term use of bispecifics. But outside of that, there haven't been any real surprises like the T-cell lymphomas with CAR-T that have sprung up as of yet.
I want to thank the four icons to my right for spectacular presentations and discussions. I want to thank the general medical oncologists for submitting cases and questions for discussion. And I want to thank all of you in person and online for joining us today. Enjoy the rest of ASCO and good night.